Hi everyone, so I'm Addy. I'm a student physiotherapist from the University of Nottingham. This presentation is going to be on falls prevention, covering background information, interventions, and education advice. So to start, I thought I'd give you some figures. So older adults with dementia fall 2 to 3 times more than cognitively healthy older adults, and 60 to 80% of people with dementia fall annually, which demonstrates the importance of falls prevention. But despite this, there are no guidelines for falls prevention specifically for people with cognitive impairments, and there are actually only 2 lines on this population in the NICE guidelines. So this image just shows the potential contributing factors to a fall. These include psychological, environmental, physical, sensory, cognitive, and medical factors. The underlying factors shown in the image are specifically relevant for individuals with dementia. So it's important that we develop an understanding of falls risk factors. Medical factors include psychotropic medications like antipsychotics and benzodiazepines, which manage behavioral and psychological symptoms of dementia, but can increase falls risk by affecting cognitive function, resulting in sedation, slow reaction times, and impaired balance. Syncope is one of the primary causes of hospitalization in those with dementia, often resulting from drug-induced orthostatic hypertension. It is underdiagnosed due to potential inability to verbalize or remember specific complaints, emphasizing the importance of the awareness of the symptoms. Psychological factors include fear of falling, impulsivity, and behavioral disturbances. Schwack et al. Found wandering behavior resulting from impulsivity, agitation, and restlessness indicated by short walking bouts increased falls risk. Anxiety may relate to neurochemical changes associated with dementia, impeding postural responses to perturbations and reducing stride length, lowering gait speed, again increasing falls risk. Causes of physical and sensory factors include a sedentary lifestyle. Hartman et al. Found people with dementia are more sedentary, which is strongly associated with negative health outcomes, mortality, and lower cognitive performance. A decline in executive function can lead to apathy, and a lack of motivation of goal-directed behaviour, lowering engagement in ADLs. Both these factors lead to deconditioning, reducing strength and balance, increasing falls risk. Environmental factors include walking aids, as the attentional demands associated with them can lead to an impaired ability to maintain or recover balance. Misinterpretations of the personal environment may cause illusions and misperceptions of depth, light intensity, colour, pattern, and temperature, which can result in environmental hazards. So the cognitive factors are extremely involved, and I could probably have a whole presentation on them. But if you'd like to know more about the link between cognition and gait, the link at the bottom of the slide in the blue text box is quite good. But to summarise, the motor and sensory systems are linked by higher order neurological processes and cognition. Research shows cognition has a key role in regulating gait and balance. Increased levels of cognition are required for motor planning and adapting to environmental changes, which therefore means that cognitive impairments increases falls risk. So detailed on the slide is the NICE fall risk factors. A history of falls in the past year is the single most important risk factor and predictor of further falls. Red flag questions include a history of any unexplained falls, where there is actually no clear cause, any dizziness on standing if able, and any new or worsening observed balance or gait problems not previously investigated or managed. If you or a carer are concerned, refer the patient to their GP for a medical review. And on the right hand side of your screen, the falls risk assessment tool is shown. However, different trusts may use different tools, but this is just an example. So what are the impacts of falls? For those with dementia, there is a significant increase in fall-related injuries. The effect is not purely physical and can lead to negative mental health outcomes such as fear of falling, loss of autonomy, poor quality of life, greater isolation, and depression. For those with dementia, falls account for 14% of hospital admissions. 85% of people with dementia with a hip fracture stay in hospital for up to 14 days, which is actually 7 days more than the average stay. and 34% stay for over a month. People with dementia and a history of falls are 5 times more likely to become institutionalized. Fear of falling is a huge psychological impact from a fall. It is defined as a persistent feeling related to the risk during one or more activities of daily living. The clinical presentation includes functional decline. Becoming fearful of falling and hurting themselves causes a reduction in activity. This could present subjectively when asking them or their carer about their activities or increasing dependence on the carer. As the image shows on the right, reduced ADLs can lead to muscle weakness and loss of balance reactions, which actually increases the risk of falling. Hence, fear of falling becomes a positive feedback loop and a cycle of fear, reducing activity, which reduces physical function, increasing falls and fear. Anxiety prevents activity. This may present as someone saying, I'm not going to garden anymore because I don't want to fall and break a bone. Biopsychosocial impacts include activity avoidance, leading to frailty, social isolation, and change in social roles, reducing quality of life and increasing risk of depression. Psychological factors can be actually more disabling and have a greater impact in function than the fall itself, showing the importance of being aware of these factors. So these are just some simple strategies to help manage fear of falling. So you can reflect on a person's abilities and successes. This may increase confidence when reflecting on a time someone achieved what they actually set out to do, increasing motivation and self-belief. It is valuable that carers or family members engage with the individual if someone is fearful. This may involve taking part in the activity or providing verbal encouragement. And set small, achievable goals that don't seem overfacing. This may include walking a shorter distance or incorporating regular rest breaks. Goal setting also gives a meaningful outcome to work towards and provides an outcome measure. Finally, practice the tasks or activities that cause anxiety. This may involve breaking tasks down into more manageable chunks for the person. So what are the impacts on the carer? So high levels of distress are associated with caregiver burden, which can increase acute care service use. Caregivers may report more potential harmful behaviours towards the caree, such as lower quality of care and resentment. Adverse medical events increases the strain during crisis, depleting emotional and physical reserves. If these events are associated with increased care-related emotional difficulty, intervene ensuring appropriate support and services to improve well-being of carer and caree. Emotional care-related difficulty can be experienced through several mechanisms. The need for urgent decisions and medical care, adjusted routines, and decline in the abilities for self-care and participation in social activities, and fear of falls. Concerns about the caree falling can result in increased vigilance and being overly supportive, resulting in dependency and reduced participation of the caree, leading to reduced independence causing deconditioning. Ultimately, this further restricts the carer, increasing caregiver burden. For me, this actually highlights one of the roles of the Admiral nurse. So just so you're aware, these are the recommendations provided by NICE. There is currently insufficient evidence for multifactorial interventions to reduce falls, specifically among the elderly with dementia or cognitive impairments. However, there is evidence to support individual interventions, and there is a review of NICE guidelines set to be released in 2024. So the goals of physiotherapy include prevention of further falls, training to cope with further falls, preventing long lie, and improving confidence. If someone has fallen or is at risk, an assessment would involve assessing gait, balance, joint range of motion, muscle strength, and functional ability, including observations of how they perform everyday tasks like standing. So Lee et al. Found strength and balance exercises to be safe and reduce the rate of falls by approximately 30% among older people with cognitive impairments. Balance exercises should challenge static and dynamic balance, and cognitive challenges can be added for further progression. Recommendations for strength exercises include training major muscles 2 or more days a week. Taylor et al. Found carer involvement with exercises increase motivation and adherence, which encourages carers and family members to get involved with those with cognitive impairments, exercises, or exercise programs. So exercises should focus on being functional and enjoyable. So I had feedback from a lived experience group, and they said they preferred interventions which were fun and actually personalised to them. So Sitzer et al. Found functional activities slowed decline of cognitive ability, improved orientation, memory function, and performance of functional tasks in those with Alzheimer's. A functional activity may include putting food or plates in the cupboard overhead, or gardening. So if you think about gardening, it includes like light digging, carrying, bending, and squatting. So it's working muscles and incorporating aspects of strength and balance training. So a personal favourite of mine was boxing as an intervention, which Long et al. Also used and had good feedback on as well. Group participation can also support engagement and adherence in exercising and provide psychosocial benefits, reducing social isolation and loneliness. So informal feedback from Long et al. Found participants really enjoyed the camaraderie and were motivated and comfortable by the shared experience of being with other people with dementia. Long also found abilities were maintained, deterioration was prevented, and confidence increased. And confidence actually increased, easing anxiety. So ask a physiotherapist about any potential local programs. And finally, ensure relevant resources have been provided. Exercises should be clearly noted down with images where appropriate, and exercises should be individualised. So this video is a good resource from the Chartered Society of Physiotherapists, and it provides some examples of strength and balance exercises. It's a bit too long to play now, so you can have a watch a bit in your own time if you'd like. And these do provide general exercises, but physiotherapists will provide an individualised program. So what are the benefits of exercise? I think this quote kind of summarises the effect of exercise quite well. So if physical activity were a drug, we would refer to it as a miracle cure due to the great many illnesses it can help treat. So benefits of exercise for dementia include weight-bearing exercises, maintaining bone strength, reducing risk of osteoporosis and fractures. Resistance exercises increase muscle strength, walking speed, and enhance performance in ADLs. So exercise plays an important role in reducing progression, improving cognitive function, sleep quality, improving ADL performance, and reducing fear of falling. And this is actually just naming a few of the impacts. So it's worth considering the effect of music. So music is something that's been quite interesting to learn about and quite fascinating when I've been kind of using music on placements. So individualized or relaxing music can lower agitation, reduce physical effects of stress, and improve sensory motor function. So music overrides stressful environmental stimuli that the cognitively impaired person cannot actually synthesize, and instead evokes remote memory with pleasant associations, decreasing agitation, reducing the risk of falls. It's also worth noting the increasing evidence base of technology-based interventions, with literature supporting the use of Wii Fit and video game interventions. So it's quite interesting for the future how kind of technology is going to influence treatments and interventions. So education and advice for carers. So how can you encourage and maintain activity? So create a daily routine with small rituals, as predictability can be calming and relaxing. So a good few examples maybe, before when someone gets up from the sofa, maybe do a few sit stands, so sit back down, stand back up, or when someone's making a cup of tea, do some squats while the kettle's boiling. Try to allow for independency. So this can be achieved by giving the individual a role or a task, such as doing the washing up, peeling the vegetables, pairing socks. So do less for them while encouraging them to do more for themselves. So it can be quite tempting to kind of help with uh, a lot of activities, but try to encourage the person to do more for themselves. Um, so if motivation is an issue, make the tasks functional. For example, walk into the kitchen to get a drink, um, instead of carers actually carrying it to them. So plan activities that you can both enjoy, and encourage other activities such as gardening, baking, listening to music, singing, dancing, or playing cards. So these are quite functional ways of doing activity, and ultimately, it is fun. Um, so reassure the person about their surroundings to increase confidence, and reminisce at the same time. So recalling how things were done in the old days can make tasks more meaningful, enjoyable, and actually provide cognitive stimulation. So environmental considerations. So ensure there is adequate lighting, for example, night lights in the bedroom and hallways. Turn lamps on in dimly lit rooms. Provide visual contrast, so use contrasting colour to define objects from the background. Examples include applying bright non-slip tape on the edge of each step or at the bottom and top of the stairs, and having darker floors and lighter coloured furniture. Keep pathways clear, so it's important to declutter, removing anything in the pathway causing a trip hazard. So ensure safe footwear. So are the shoes suitable for the weather? Is the sole of the shoe worn? Should they be wearing socks with no grip? So obviously we can have grippy socks. And bathroom safety is imperative, as it is one of the most common places to fall. For example, having non-slip mats or effective lighting may be beneficial. And check for any loose wires or carpets. If more guidance is required, or if someone will benefit from a home assessment, then it may be necessary of an occupational therapist. So, how the caregiver communicates with the person they're assisting is an important factor in reducing the risk of falls for people with dementia. So, obtain the person's attention, reducing distractions, gain eye contact, and be mindful of your own approach. So, remain calm and watch your own facial expressions, gestures, and give people time. Try not to rush them, so they keep calm. So give thought to how instructions are given. So use short, simple sentences. So this can include like suggesting one step at a time, use cueing, and allow for time, and provide the person with encouragement. Finally, what should you do if someone falls? So do not try to lift the person. You risk injuring yourself and potentially risk making injuries worse. Um, So if they hit their head and you are worried about them being injured or ill, so call 999. And if you are unsure or have any doubts, call 111. The best thing to do is try to talk to them and keep them warm, comfort, and hydrated. Ask about any pain in the head, neck, shoulder, wrists, hips, and knees. People with dementia often have difficulty expressing pain, so indicators of pain, including calling out or groaning, fidgeting or rubbing the body area, grimacing, and changes in usual behaviour. The Abbey Pain Scale is a tool used to measure pain for those who cannot verbalise it. So if someone is not injured and will be able to stand up, the image shows the guidance provided. The link below the image um, provides a good resource to provide advice about what to do if someone falls. So that's shown at the bottom of the image. And that's in the presentation. So thank you for listening, and I hope you found that interesting. See you later.